Good morning, everyone. My name is Lisa Hamilton Service, and I'll be your presenter for today. As you were already introduced to this unit, you have now come into an appreciation that this is a behavioral medicine unit, and that is just simply representing the fact that we have both psychiatric and medical patients. The medical patients and psychiatric patients come together for us to be able to understand and appreciate as nurses that one affects the other. So for us to be able to care for our patients effectively, we have to understand how psychiatric illness will present, what it does to an individual, how it impacts their lifestyle, as against how the medical illness is impacted by psychiatric illness and vice versa. So for today, we're going to begin a series of lectures that speak primarily to the psychiatric disorders. First, we want to be able to appreciate what they are, how they're diagnosed, what World Health Organization says about psychiatric illness, and we will also look at the principles of management. Today, as you begin your journey on this unit, you'll also be able to identify, once you come into contact with a psychiatric illness, how it affects the individual's lifestyle and how that lifestyle is now impacted in terms of the medical diagnoses. Today, as we go through our lecture, I'm going to ask that you write your questions down, and at the end, I will allow for 5 to 10 minutes so that your questions will be dealt with. As we go through this lesson today, two things we're going to be doing. We're going to be having the PowerPoint lecture, and we're also going to look at a case study presentation for a young man called Henry. We are also going to be using our handouts, handout 1, 2, and 3, to augment the information in this lecture. We can appreciate the fact that there's a volume of information as it relates to schizophrenia that we will not be able to adequately cover in 15 minutes. But question and answers, we'll be able to identify and solve any issues that you have. So today, for our objectives, we'll be looking at defining schizophrenia, looking at the etiological factors that are associated with schizophrenia. We will identify or outline the epidemiology of schizophrenia. We will identify the 5 types of schizophrenia that has been put forward by the Diagnostic and Statistical Manual for Mental Disorders. And finally, we will outline the goals of management. So by way of introduction, the World Health Organization tells us that approximately 2.4 million of adults are living with schizophrenia in the United States. When we look at the worldwide picture, then 3 million adults are diagnosed with schizophrenia annually. This makes it a concern for us. It was also alarming for me to look at the ratio for schizophrenia diagnosis in the population. It says 1 in every 100 person will be diagnosed with schizophrenia in his or her lifetime, and that is of concern to me. The disease itself has no cure. However, there are lines of management that will help us to focus the individual to returning to a higher level of social and occupational functioning. We also are told by World Health Organization that this illness comes in 3 stages. So for us to be able to diagnose, we have to be able to define for ourselves what happens in each stage. There is a prodromal stage, which is the beginning where there are onset of symptoms, and we might find a person having symptoms such as magical thinking, self-care deficit, and relational issues. This will progress to becoming full-blown active symptoms, wherein the active phase you will see predominantly delusions, hallucinations, and factors now that will impact the individual's daily function. There may also be what we call the residual phase. After going through the other 2 phases, the individual is treated and gets to the level where he or she is able to function with minimal symptoms, however, still functioning in a role that is equivalent to his or her peers in society. So as we go through our lecture today, we're first going to look at the case study. So who are we going to be talking about? There's a 20-year-old gentleman who is called Henry. Henry was brought to the emergency room by his parents. He was said to be talking to himself, not caring for himself, decrease in nutrition, not taking care of his grooming of himself or his room, his social environment is always filthy, disorganized. Henry was said to be functioning effectively until age 16 when these symptoms started. His parents recognized, however, that since starting to work at a corner store, the symptoms became even more predominant, that he was now unable to cope or function. He dropped out of college, and he has been living with his parents since and has not formed bonds of friendship with his peers in society. So what is schizophrenia? Schizophrenia is defined as a psychotic illness, and it is manifested by negative and positive symptoms. These negative and positive symptoms of schizophrenia will impact his or her cognition, judgment, feelings, behavior, and eventually lead to social and occupational dysfunction. The epidemiology of schizophrenia, according to the Diagnostic and Statistical Manual, the lifetime prevalence of schizophrenia is 1 to 1.5%. It's also said to be a disorder of the young, meaning that it begins during the age of onset rather is 15 to 35 years. So the individual who is seeking to form alliances, develop friendships, learn and grow in terms of their occupation, seeking a career, will be impacted to the extent that there is no interest in growing or developing in these areas. The individual who is diagnosed with schizophrenia, usually 50% of those who are diagnosed will be diagnosed before age 25 years old, and that makes the lifetime issues even more predominant for such an individual. As we move into the etiology, we have identified that the cause of schizophrenia is unknown, but the factors that are associated with its development would be biological factors, genetic factors, and psychosocial and environmental factors. The biological factors has two groups primarily. One, the dopamine or neurotransmitter theory, and the physical impairment of the brain. So if there is any injury or insult, that may result in increased brain activity or decreased brain activity, may result in schizophrenia. The theories that were put forward to us by Kaplan and Sadok tells us that the dopamine theory is that increase in dopamine in the in the limbic system will result in positive symptoms, whereas decrease in the frontal lobe will result in negative symptoms. The genetic factors is in line with, if there is a family member who has schizophrenia, it increases an individual's risk to develop schizophrenia. If the parents were diagnosed with schizophrenia, it increases the child's likelihood, if it was one parent, by 10 to 15%, if both parents, 35 to 40%. If it was also seen in genetical twin studies where if one twin was diagnosed with schizophrenia, the likelihood for the second twin to be diagnosed was increased by 50%. In terms of psychosocial and environmental factors, there are two primary focus, one on the familial tendencies and one on the personal tendency. So if there is family discord, altered family dynamics, if there is disturbance or dispute in terms of family relational problems, if there is bonding or relational issues between mother and child, it increases the child's risk for developing schizophrenia. Personal factors will include identity, self-image, body concepts, my reality of who I am as a person. If that is thwarted or warped in any way, it increases my risk of developing schizophrenia. When we look at that and the presentation of each individual, it leads us to the point of the types of schizophrenia. And according to the Diagnostic and Statistical Manual, again, there are 5 major types of schizophrenia. One, the paranoid type, disorganized type, the catatonic type, the undifferentiated type, or the residual type of schizophrenia. The type of schizophrenia will also speak to the symptomology that will present to making such a diagnosis. So for the paranoid type, it is characterized primarily by delusions, hallucinatory experiences, jealousy, and religiosity that is exaggerated. There's the disorganized type, which is characterized by regression of to primitive levels of behavior so that the individual will be able to cope with reality. So I'm having an issue and I'm not able to deal with my friends and my peers on my level. It's easier for me to regress to a younger stage of functioning so that I'm able to cope, and that defines disorganization of schizophrenia. The catatonic type is characterized by movement disorder. It might be increase in movement or decrease in movement. Also, abnormal posturing or speech pattern disturbances. For that, I want for you to turn to or handout number 2. It lists out all the symptoms that will be presented under each type of schizophrenia. The residual type, when we look at that, basically speaking to an individual who's been diagnosed with schizophrenia, has been treated, however, still has pervasive patterns of symptoms, but is able to function social and occupationally. So when we're talking about the signs and the symptoms, I just want us to focus a little bit more on the positive and negative symptoms. And handout number 1 speaks to the positive and negative symptoms. So what are the positive and negative symptoms as you look at your handout? The positive symptoms are diagnosed primarily by those presentations that are more externalizing. The individual will express his emotions in an exaggerated form. Hallucinations, hearing voices, or seeing persons that you and I are not able to see in everyday environment. There's a disorder of thought, the word formation, neologism, formation of new words, thought blocking, that becomes more predominant for the person experiencing positive symptoms. And the movement disorder, the person is unable to sit still, is restless, agitated, or have acute posturing, and the diagnosis will be associated with positive symptoms. For the individual experiencing negative symptoms, it's predominantly disturbance in emotional patterns. So we will see the individual being very sad, the affect might be flat, they're unable to express joy or any type of emotion that will depict pleasure. So how do we manage these symptoms? How do we manage these persons? And there are 3 primary things that we will look for in terms of management. Our management will focus on safety, team approach, patient and family education, and return to social and occupational functioning. The goal for our treatment is to help each individual to return to that level of functioning that is in keeping with their peers in society. So as we look at the case that we were discussing earlier, Henry, how does Henry's age compare to the epidemiology of schizophrenia? We saw from the case study that yes, Henry was diagnosed at age 20 years, but according to his parents' report, the symptoms began when he was 16 years old. His family dynamics, his parents had family patterns of disturbance, and he also saw that they divorced when he was 20. When we compare Henry's management with the literature, yes, there's the acute care setting where he was treated with medication, but he was also referred for psychological evaluation and counseling therapy with focus on returning to his level of social and occupational functioning. So he went back to his job, he went back to playing with his friends, he liked soccer, so he went back to playing soccer with his friends. He still exhibited or discussed that he had symptoms that will cause him to feel as though he would not go back to his games with his friends. However, with encouragement and family support with regards to that dynamics, he was able to do so. So at this time, I'm going to pause so that we can go through some of our questions that are listed. You can take 5 and then we will return for those questions. Thank you.